All right, so let me do this then. Let me introduce to you Dr. Fredrik Eriksson, who's the director of the European Centre for International Political Economy. He's very kindly joining us by Skype. He was supposed to be here in person, and there was an issue in getting his visa sorted out on the flight, but he's very kindly agreed to give us the time and join us. And we're very honoured to have him here as well, using the technology of Skype. Dr. Eriksson, can you hear me okay, sir?
I can hear you fine.
Wonderful. So thank you again for joining us. Shame we couldn't have you here in person. I hope we get you to India soon. And I want to ask you, just to start off this conversation, if India is now determined to create a national health system with a national coverage, what do you think India could learn from Europe, both good and bad?
Well, thanks, Riz. First, let me apologize for not being there myself. Having these problems yesterday with my visa. I've been in and out of India several times the past month, so I'm sad not to be back there today for this conference. What we can learn from Europe is, I think, firstly, that universal public health system with universal coverage tend to have very strong positive effects on public health. I mean, that was obviously clear when European countries or other parts of the world rolled out universal healthcare system several decades ago. We could also see that they had very strong positive effects on labor participation, on productivity, and that you get an economic boost from having people with solid, good access and speedy access to healthcare when they need it. I think it's also important that countries work with the demographic profile of the country when they construct universal healthcare systems, both in terms of how the system should be paid and what type of healthcare services it constructs in order to deliver to people. Another lesson, I think, learned from Europe, where Europe managed to do it in a fairly good way initially, but where we're beginning to have problems now, is finding the right balance between what sort of benefits that people should have the right to have from the system and what contributions they should make to the system. The balance between them is quite important, because after a while you can end up in a situation where the demand for healthcare vastly exaggerates or is vastly bigger than the actual supply, and finding that balance that becomes politically difficult. Lastly, and I think this is also an important lesson for Europe, that finance your healthcare. Don't do it by taxing the inputs that you use in producing healthcare. Find other spaces in order to pay for it. And I think this is a lesson which I think is important for India and several other emerging countries today that are in the process of rolling out larger national healthcare systems. Avoid seeing the inputs of healthcare and, as a consequence, impeding the price system for inputs to work properly.
One thing I'd like to get your perspective on, Dr. Eriksson, is the economic structure in Europe. And I wonder, for example, why is there generally a lack of productivity in the European health systems?
I think there are many explanations behind that, but at the heart of it, I think, is that many European countries, not all, but many European countries have failed to get prices and incentives right within the healthcare system. And this basically means that people in the healthcare system are working towards ends or are working with the wrong sort of focus. They are focusing or concentrating on wrong things in the healthcare system, and that tends to be very costly. And you can try to disentangle that or break it up in different sort of elements. First of all, we have a problem when it comes to utilization of capital and technology, that the cost of capital and technology is far too high in relation to what that capital and technology actually performs. And this has partly to do with the fact that expensive medical equipment tends to be underused. We have, in many parts of Europe, a management structure of healthcare which is simply unprofessional. where managers of hospitals or healthcare centers simply don't have the requirements or the skills that are needed in order to manage a hospital in a good way. We have a political system above that, which tends to give political impulses to the management of hospitals or healthcare units that also lead healthcare staff to focus on the wrong things. We have problems with generally allowing medical specialization in the system to get supported by economic specialized system in our healthcare systems. So we spend a lot of money on different sort of inputs or different sort of costs which are expensive, where we should basically trade and allow the supply to come from other countries rather than to try to supply it on their own. And this, of course, has to do with the fact that in many countries in Europe, healthcare systems tends to be organized along regional monopolies, where you don't have competition, where you don't have strong incentives in the system to behave more rational. And that basically leads us to a situation where we today in Europe, we have to add more and more money every year just to keep up with the output of the previous year.
Is that the only reason, Dr. Eriksson, that Europe is having trouble keeping an eye on costs, or are there other factors?
Well, there are many other factors as well. I mean, behind the increasing expenditures of healthcare, of course, also lies the fact that we have increasing demand, that we have a demographic situation in Europe where a large group of elderly people tend to demand healthcare much more intensively than they did in the past. We also have much better supply in healthcare, and that supply also tends to be quite expensive, in the sense that we can today treat or cure diagnoses that we couldn't do in the past, and many of these treatments come with a fairly hefty price. My point here is basically that many of these in the system, or many of these factors that are pushing expenditures in the system right now, they can be dealt with in a more rational way. However, what they cannot do is to take away the fact that if you want good healthcare for all, delivered fairly speedily, we cannot avoid raising the total amount of money that is spent on healthcare every year. We cannot avoid the fact that healthcare is going to take up a far larger portion of total expenditures, of public expenditures or private expenditures in the future. And I think this is one of the problems in Europe today, that we have begun sort of the process of managing healthcare by defining how much money we're going to spend each year, especially within the public system. And if you start the planning of a healthcare system with the total amount of money it should be allowed to cost, you basically have to manage the system and create regulations and create management impulses to the way healthcare work, which is going to lead to inefficient results. So we need to get away from this sort of idea of capping total expenditure on healthcare, because better supply and more demand will require more money.
Well, a quick thought, a couple more questions for you, if I may, sir. One thing that came up earlier in our conversations here in Delhi was the issue of private and public hospitals and the differences between them and how the private and public sectors differ. I know you've been involved in a number of hospital reform projects, and I wonder what you find to be the most common area of concern that you've come across and how difficult that is to fix.
Yeah. I mean, the most common problems that I've faced when I work on hospital reforms, both in the 1990s and the 2000s, which was a bit surprising to me, but it basically concerns unprofessional management of hospitals. The fact that you had the wrong people leading hospitals or other healthcare units, and they were organizing work in a way that was simply inefficient. People were spending too much time doing the wrong things. And I think this is a problem which has been pervasive in many healthcare systems. It's also a problem that you can find in not just in public healthcare systems, but also in private healthcare systems, depending on what sort of ownership or what sort of management control they have. So getting management right, getting a good organization where you use your staff, you use the skills of the staff, and you use technology in an optimal way, that's basically how you're going to also improve the efficiency of each healthcare units, and that's also how you're going to increase the efficiency of a healthcare system at large. One thing we have found, and what I think a lot of people have found in the past as well, is that regardless how you organize your healthcare system, if you have single payer system which is represented by a government, if you have almost total government ownership of hospitals, healthcare centers, or if you have a lot of private participation there, regardless of the choices that you're going to make, you need to ensure that there's going to be competition in the system, competition between the performers of healthcare, as well as competition between those that are supplying inputs to the system. Because if you take away the element of competition, you take away a very strong incentive that exists for both patients and producers to learn and to move systems in the right direction.
Dr. Eriksson, I'm going to just ask you one quick question before we go. You mentioned earlier about the risks of capping healthcare spending and creating all kinds of complications and regulations. And we're discussing the regulatory aspect of healthcare a little later in the afternoon. But while we have you here, it's an area I know that you've written a number of books on. So I want to get your perspective on what role you see regulatory systems playing in healthcare.
Well, regulatory systems will be present in so many different parts of healthcare in the future as well as been in the past. We're going to have regulatory systems addressing products, professionals, the performance of healthcare production. I mean, let me put it like this: if I'm going to give two sort of recommendations of what you shouldn't do with your regulations of healthcare systems, the first one would be, and you mentioned this in your question, don't regulate or don't cap the total expenditure of healthcare. Don't let that sort of cap be the overall framework for how you want to organize your healthcare system. So that's the first point. The second point is that don't regulate prices, neither healthcare delivery prices nor input prices, because if you begin to regulate those prices as well, you're going to build in a lot of inefficiencies in the system, and you're going to get a lot of actors within healthcare to focus on the wrong things.
Dr. Fredrik Eriksson, thank you so much for joining us. I'm glad you're able to contribute to our debate here and our discussions. We wish you a trip to India sometime in the near future. Thank you, sir.
Thank you.
Thank you. Well, I'm glad we were able to get his input. Dr. Eriksson has a lot of experience in this area, and he's given us a couple of things to think about for this next part of the discussion. Let me invite up the panelists we have for this session. I start with Professor Bengt Jönsson, who's here with us. He's the Professor Emeritus of Health Economics at the Stockholm School of Economics in Sweden. Professor Jönsson, thank you, sir. Come on up. We also have with us Mr. Amit Bakliwal, who's the Vice President of Technology and Services at IMS Health. Grab a seat, come on up, sir. And Dr. Anita Katrina Wagner is the Associate Professor at the Department of Population Medicine at the Harvard Medical School and Harvard Pilgrim Healthcare Institute in Boston. Dr. Wagner, please come on up. Please come grab a seat. Well, ladies and gentlemen, we've got a lot of food for thought, and I know some of you have questions from the previous sessions. Though we're kind of focusing on certain areas in each of these sessions, there is an overlap, and we can certainly weave in some of the questions you have. to touch on topics that we have already covered because they are all interconnected. It's something that's very clear. And Dr. Eriksson there raised a couple of issues which I want to bring in. But I'm going to start off with a couple of questions before we open it up for you, as I did before, to keep this interactive and as dynamic as possible. Dr. Wagner, I'm going to start off with you, if I may, first, please, and ask about medicines. And this is interesting because I know we touched on this a little earlier when the issue of medicines came up. And I know you believe that medicines are kind of taken for granted, that they're often treated simply as products and commodities, and that you believe that universal health coverage cannot be achieved without looking at medicines in a new light. So what is that new light, and why do you feel that there's this misunderstanding?
Yeah, okay, well, thank you very much, Reese, and thank you for having me be part of this very interesting day. So when it comes to, let's maybe just focus back on the two parts. There has been an evolution in terms of health systems thinking, and there has been an evolution over the past 25 years in medicine's thinking, but they don't necessarily merge. And so let's pick up where I think Dr. Travis left off earlier at the two key cornerstones of universal health coverage that she mentioned, which were, of course, achieving health of people through appropriate access to needed care that is of high quality, and risk protection as two of the key goals of universal health coverage. I'd like to add two more to those, and we touched upon those, which are satisfaction with the healthcare system on the part of the patients and the providers, and importantly, sustainability of systems. Without sustainability of systems, we won't be able to talk about the future. Now, medicines play key roles for all of those. Clearly, medicines are needed to prevent premature mortality, to decrease suffering from illnesses, to keep people productive, caring for their families, earning money, and so forth. We know the value of medicines. We also know that medicines are one of the key items that patients expect from healthcare systems, and that doctors need, and nurses need, and healthcare workers need to provide quality care. In terms of risk protection, medicines play a key role because in most countries, low and middle income countries, and India no exception, most medicines are purchased in the private sector. They are purchased with out-of-pocket money. It's my understanding that in India 72% of household healthcare expenditures on health go to medicines. So from a risk protection perspective, making sure that medicines are part of a benefit package in whatever the system develops to be towards universal health coverage, medicines explicitly being a piece of that is key, and that goes much beyond the usual focus on medicines as a supply chain item and as a commodity that's just there when we talk about healthcare. And then lastly, of course, medicines play a huge role in when we think about sustainability of systems. Medicines are more than 40% of total healthcare expenditures in India. Only less than 10% are paid for from public funds. So lots of money is spent on the household side, lots of money is spent on the system side overall, and then unfortunately, and we can talk about this more later, a lot of that money is wasted. So it doesn't necessarily go to high value care. And that is, I think, where there is a need to look at the universal health coverage and health system streams of work in conjunction, because as systems move towards universal health coverage, they have leverage, and they can bring that leverage to bear in hopefully decreasing the waste towards more high-value care. But let me stop here.
Yeah, thank you very much, Dr. Wagner. You've raised some interesting points there that we can pick up on as well. Actually, perhaps I could get to Professor Jonsson here and ask on this issue of incentives, because I know you feel that that's something very important. Isn't there a basic incentive in healthcare in simply treating a patient, making them better?
Yeah, I think that the importance of incentives in healthcare is best shown when you get them wrong. And I think we have already have several examples here And the reason I think why they are so important is because there is the cost of healthcare. is identical to the incomes from healthcare. And while I agree totally that if you would like to create universal coverage in the healthcare system, you need a greater investment of public money. And I think that's the European experience also, where we now spend, in all countries, 75% of the money comes from the public purse. But that, of course, also means that we have to be very careful how we are spending these money, and that they are done in an efficient and equitable way, and that there is accountability for it. Because if that's not the case, the healthcare system has not a long-term sustainability. So I see this as a sustainability issue very much. If we are looking at incentives, it's right that for doctors in particular for private healthcare system, I think that doctors' actions should be driven by ethical and professional principles. That's the ground for everything. Do the best you can for the patient. But even if we have more money in the healthcare system, patient is paying less. It doesn't mean that we need to have a system to get the resources. We have to pay the doctors and hospitals, etc., and that's very important. So the tradition has been that you usually pay hospitals for time. In Germany, you pay per number of bed days, and you got an enormous amount of bed days. And when you change to DRG payment per hospital episodes, overnight the number of bed days drop by more than half. You pay doctors per activity, and if you pay for activity which is not having any impact on health, you don't get very much health. So of course where we are coming now is of course trying to create these incentives. And while focus is on very much on the professions, I think that we more and more also have to see the incentives from a patient point of view. And I think particularly that's relevant for India, where you have a combination of private and public organizations. If you get incentives to go to the hospital, instead of go to the primary care, you will lose a lot of resources. If you design a healthcare system with no incentives for prevention, and for engagement in the patient in this also. And so the incentives for the patient, and then I would like to also mention, I think this is increasingly important, particularly relating to medicines. The incentives which we are more and more now is looking for is of course the incentives for innovation, taking new technologies into healthcare. And of course what we see, and has been said here several times, is that those new technologies seems to be also very expensive. Sometimes they may also be of an unclear value for health. But we have to handle this, and of course we have to think about it's not only pharmaceuticals. I think in India, what I've seen here, the enormous investments in information technology, for example, which has the possibility to a total reform of the healthcare system, to really be a disruptive technology, because what we need for the healthcare system is technologies which are of course less expensive, which is really have an effect on health, and which really can empower the patient to participate in the healthcare system. So I'll come back to the details of this, but I think this is just to show that incentives is actually absolutely crucial to this.
Actually, that's, yeah, and you've raised some very interesting topics there, and I'm curious at some point, hopefully, to discuss how this sort of the outcome, the incentive of an actual outcome as opposed to activity by a doctor might be a key factor to be measured as an incentive as well. Dr. Amit Bakliwal, I know you wanted to show us a couple of slides relating to this information, or your sort of view on India's healthcare system, so I'll ask you to, yes sir, get out your way. Should be on, I think.
Yep, that's on. I think it's okay.
Maybe the podium
It's
is
fine.
on. Oh, it's on?
Yeah, I think so.
Can't hear you very well. Though.
Maybe
Yeah. Will this help? You want a handheld?
that's
or
okay.
is that okay?
That's fine. Okay, I'll just do that. That's okay, I'll move. I'll do you.
One is on. It should be okay.
I'll just move on.
Okay. Oh, you want to use this?
Yeah, actually, that's good.
Yes, you don't have to hold that. Thank you, sir.
Okay, first of all, thank you very much for inviting me to come here. My name is Amit Bakliwala, I work for IMS Health. I've been in quite a few of these forums in India in the last few years, talking about accessibility, talking about universal health. I think one of the most interesting yet challenging areas is how do you create an implementable, actionable roadmap for India to drive universal health or anything closer to that. So I've got a few slides because I think it's good to have a dialogue, but especially when you've got a large engagement and a lot of people sitting, it's good to show them slides because you can see something visually and it kind of starts giving you some perspective around things. So this is what the government came out around what they want to drive around the universal health assurance programs. Part of this is around driving affordability, making healthcare affordable, making it accessible, and obviously assuring that everyone in India should get some level of health which is of high quality. The challenge with that is, if you see across, there is a lot of emphasis on driving healthcare infrastructure setup, having primary care setups, and obviously at the end of the day, making it economical for the whole population to be able to access this. To the points which were raised before, and I reiterate it, is the infatuation though in most healthcare reforms, and India is obviously part of it, is around pricing, and medicines obviously become a key component of that around driving pricing as a way of driving access. One of the key things we've looked at, not only in India, but across the world, is bringing prices down and controlling them never drives access. So I think one of the key challenges is how do you drive a political agenda which is away from using pricing as a lever only to drive accessibility, where affordability is obviously important, but you need to first get the patient to a particular healthcare facility. You need that patient then to be able to get access to certain quality healthcare workers and the way of delivery of care. And at the end of the day, someone has to pay for it. So unfortunately, the whole pyramid is inverted, where most of our effort and policy has been driven around pricing and drugs versus the key issues that we still have from a healthcare infrastructure development in primary care, in being able to get those people, especially living in rural or even in urban poor areas, accessibility to certain infrastructure and some kind of healthcare where they should be able to get treated or at least seen by someone. So I think this is where one of the challenges we continue to see is the healthcare spending continues to be a big challenge, where we look at public spend is still significantly low. I know Anita from a long time in some of the work we did in Thailand as well, and Thailand is a great example of a country where it's a low middle income country. We've got universal healthcare and everyone has actually good access to innovative products as well as generics in the market. If I look at Singapore, where I'm currently based, it's exact opposite, high affordable country, but out-of-pocket spend is still very high, where the whole drive is around preventive care and getting people to start taking care of their own health. So from India perspective, I think the key takeaway that everyone needs to think about is what's the India-centric model, where you've got still challenges around people being able to access infrastructure. There is still a literacy challenge. So all of these models are great, but how do you get an illiterate or a poor person to be able to think about healthcare as a key agenda item when they really don't know what's going to happen to their meal at the end of the day? So using that The other area to think about, and I 100% agree and align with it, is our public spending. Across markets, you can look at any market where healthcare accessibility and access has gone up. The spend of public healthcare as a percent of GDP or relative to their split of 100% is anywhere at least 50% plus. Even in emerging markets like Chile, Indonesia, we've seen at least 50%, 45 to 50% of public spend, which is there. The other one is per capita spend is still extremely low in India. So we can keep on fighting on the split, but you're comparing apples to oranges where India is still less than $100, right? $60 or $70, where even other emerging markets, we're looking at multiples of that spend on health. And a big part of that obviously comes from public, but also around private insurance or some level of areas around it. So the key point I think Riz asked me to stand up and talk about was, so what does it mean? I think in India there are two areas to think about. From a public standpoint is how does the government really look at their role? Are they going to be the provider or the payer? And if they're going to be the payer, then how do they really look at investments in the public and the primary care settings? How do you drive an incentive structure which is aligned for the private sector to support on the secondary, tertiary areas and get the patients the assurance and the health programs that they need to be able to drive certain things? Okay?
Thank you very much. Thank you. Dr. Bucklywell, thank you. So we've raised a few issues and some that have come up from the morning as well here. What I'd like to do is, again, I know many of you have questions, so I'd like to open it up and give you the chance to ask our distinguished panel about this topic of, that we're discussing here of building the health systems and designing health systems. If you have any questions, please raise your hands and we'll get the microphones to you. I know a few were outstanding from before as well, so if we can relate to those too. In fact, I know we had, Dr. Ashok, I think you had a question. Thank you. Keep talking, yeah, that's it, talking to it. It should be on, I think.
Thank you again, Riz. My question actually goes back to the previous session, but I think it may be relevant here in terms of investing in health. There's been a lot of discussion, and we've just heard more, about the need to invest more in health on a per capita basis and increasing the level of public investment as well as private. India's is 1% of GDP on the government side, all told for 4% nationwide. Including the private sector and out-of-pocket and so on. To me, one of the challenges that we haven't or don't always discuss in a forum like this is in the context of building health systems for universal coverage or universal coverage at large. Most of the discussion, at least politically and otherwise, is conducted under the aegis of the Ministry of Health in most countries. A huge stakeholder is missing from the dialogue typically, and this is a curiosity really as to why that is, because attempts have been made to really bring, say, the money per people, the Ministry of Finance in most countries to come to the table. And we have had experience at the level of APEC and so on to try and promote that dialogue. And for reasons that are not entirely clear to me, that hasn't been that easy to sort of bring about. So my question back is probably more of a realpolitik kind of question, is what can we do to really bring them together so that the people in charge of budgets recognize the value of health, investing in health, not just in the abstract, but vis-a-vis other trade-offs that they have to make.
Actually, this ties into, Dr. Bucklywell, your issue of the government as either payee or provider. And it's an interesting point that if key stakeholders such as the Ministry of Finance is missing, how difficult is it going to be to build and design a health system if, first of all, the people who are paying the money aren't really at the table?
No, I think it's a good point. So in India, as we know, health is a state subject. On top of it, at the central level, we have different authorities driving the healthcare agenda. There is no uniform view, and because of that, there is no ownership and accountability on looking at health at the national level. That gets aggravated even more with patient awareness and lobbying from the patient up around driving a policy around where health is still not seen. If you go out of this room and you start talking to people on the road, health is not a top agenda item. It's something that they believe should be there, but you only get to hit with it once someone in your family or someone else gets hospitalized, unfortunately, or you need care, and you realize what the state of care is. So I think there is a role of media, role of creating patient awareness, and getting people to start understanding the value of health, and it's an important area to push it up to the policy, to use it as an important topic, that something has to be done around it. The other one, I think there were discussions around aligning some of these departments, at least as the new government came in. I'm not really sure. I think some of my esteemed colleagues may know more about what's happened to that. But till the time you've got this in fragmented areas, I think it'll basically play, passing the parcel kind of stuff on different stakeholders, because this is not my game and someone else's.
There's clear definition needed in that sense. Yeah, Professor Jonsson, you wanted to add something?
Yeah, I think that I think here, like in Sweden, the Ministry of Finance has no money, no other money, and though they can tax the people. So the real stakeholder is obviously the ultimate payer in a public pay system is the taxpayer, and part of the sustainability, as we have here, is of course spending the money right and giving, as we say, value for healthcare. But we cannot just talk about it; we have to show it. And I think it's been said in the earlier panels here, as part of the discussion about incentives and so here, is also not only create the right incentives here, but obviously follow up and show that they are actually the right incentives. So we should try to show also to everybody involved here that we are providing the desired outcome. And I must say the problem has been that if you are looking at healthcare system, and we have seen here, they have not really been very good at showing what they have offered in reality. This is of course a major problem when we are talking about investing in health, because we could of course to some extent show that people get health care. That we can show. Number of visits. We have enormous statistics, number of hospital days, etc. But to show the impact on health is of course much, but we have to go that way if we should have some credibility for this investment.
Okay. We've just got a microphone to the front here. Angela.
Thank you. I'm just going to speak to Amit's comment, and I had a question from anyone in the panel. His comment was about, how bringing prices down really does not increase access. Also, I think you referenced, India's infatuation with reducing prices. And I think it's really interesting to share with the many people in the room some of the things the industry, have been struggling with, because I think it's probably the easiest thing to do is sort of just put price caps. And even as we speak, we have a national list of essential medicines being revised. It was started off, this list was meant to be to identify those medicines that need to be available to people through government procurement systems or through whatever system government chooses. However, it has become a weapon to basically knock industry on the head with and bring these prices down. And so that's being revised, and it's understood now. Over time, the meaning has changed. National List of Essential Medicines is a price control tool. That's what it exists. And last week in Parliament, we had a standing committee saying, well, every medicine is essential, put the whole lot in the national list, because to the person who needs a medicine, that is essential. And now, as if things weren't already bad enough, and I'm just, I don't want to be the sort of, painting a picture of doom, but I think it's important to be realistic if we are even going to start looking at solutions. To make things worse, we now have a fresh endeavor underway to put caps on patented products, which to my mind also undermines patents and severely puts a threat over innovation. So I think in this scenario, unfortunately, our government speaker who's going to be addressing us is going to come later, but he actually leads one of these committees. And I think it'll be interesting to raise this. But I did want to sort of flag it and know if there are any views from our panel members here.
Well, I can talk about the patents and some of the strategies when he does join us. But on the issue of pricing, Dr. Wagner, you said, with the amount of money that's spent on medicines, this is obviously going to be a key factor, isn't it? How do you suggest that when it comes to creating universal healthcare, that the medicines can be a linchpin in structuring the health system so that it works more efficiently?
Yeah. So I think prices are a very narrow focus that don't capture A, the role of medicines, and B, the many multifactorial approaches that we need to look at when we look at healthcare systems in general. And medicines are a really good example to do that because they are a really good entry point. So let's just imagine, let's imagine 4 connected balloons. One is, and those 4 connected balloons are the objectives. I will use the example of medicines in healthcare systems. You can use it for other items as well. And those are inherently competing objectives. One is, what we want available medicines. And we want available high-quality generic medicines, and we want innovative medicines that fill unfilled needs. So there's this balloon of need for available medicines. Then we want access. Imagine that other balloon, access to care. And access to care, we want that equitable, meaning those who need more get more. Then what we want is that we want medicines being used appropriately. We want high quality, appropriate care. Right medicines, right time, right care, right time for the people who need it, and the right place close to where they are. And we want all of that to be affordable. So, and affordable both at the household level as well as the system level. So we have availability, equitable access, appropriate use, and affordability. And now imagine those 4 bubbles to be connected. Once you squeeze on one, you'll blow out the other. If you want more people to have access financed by the government, that may blow out the sustainability of the system. Or if you want to have more people pay for appropriate care, which may well be an innovative medicine, that may not be affordable for the household. Or if you have very, very, very low mandated prices, you may not get the quality of the medicine. So these things are all interconnected. And so in order to intervene, I think we cannot intervene with one particular strategy without understanding what that strategy does to the other parts of that interconnected system. And I think with the efforts towards universal health coverage, as they are at different parts of the continuum in different countries, we have 2 sources of levers that can help us balance these inherently competing objectives. And one lever, hopefully, is the financing, going more towards creating the right incentives for high-value care, eliminating the low-value care, the waste that exists on medicines, and we can talk about where that is and how that's been done in different places. And the other part is information, and I think that gets into the session in this afternoon, where we cannot make decisions or continue to make decisions without having information on what we do. What do we pay for? Who gets it? What's the value of what we pay for? So information, and while in evolving systems, people may say that, well, we just don't have the data, we don't have electronic health records, we don't have insurance databases. Yes, that may be true, but there is always some sort of data in the system that can be used to create information, to make incremental change, and then in that process make the data better. So this maybe was a bit long-winded answer to the very targeted price question, which I think is a very focused question, but must be looked at in a very much bigger picture.
Broader context, yeah. Dr. Ashish Tiwari, you have a microphone, sir.
My question is it connect with drug price control also.
Sorry, just get your microphone up. So a little closer, sir. Just blow
Hello.
it. Yeah.
Hello. Yeah. My question is connected with this drug price control. There are lots of hue and cry in this society, in our country, that generic medicines are cheaper and they are not available in the market. But as far as doctors, consultants are concerned, they are not very much confident about using these generic medicines. So if government and pharmaceutical companies ensure that quality-wise generic and branded medicines are same, so why can't we have generic and branded medicine coexisting? For non-affordable patients, we can give generic medicine option, and for affordable patients, we can have this branded medicine option.
Okay.
Is it possible?
Let me ask, Professor Johnson, you want to tackle this? The idea that there could be almost a two-tier medicine system where generics sit next to branded medicines and then they are issued based on the affordability of the patient. Is that a possibility?
Yeah, that could probably be, but if I'm just trying to talk about from the European experience, and you know, the healthcare reform goes back and forth at a great speed. But one thing has been left in European healthcare reform, and that is the separation of purchaser and provider. And the purchaser, it's quite obvious that the purchaser, if you take a chronic disease like diabetes, if you take a breast cancer for women, the results and the value is the results of a combination. It's surgery, radiotherapy, doctor's visits, drugs, etc. I think every payer understands that there is no way you can manage this by controlling the prices, the doctor's fees, prices of individual drugs. So I think we are trying to get away from that one. We are trying to do bundled payments per episodes of illness, etc., to get away from these things, because there is a rationality in it. It should be the proper incentives. I can't, as a payer, know in front of the patient if you should have a generic or another one. That's up to the responsibility. But from a payer perspective, we obviously will pay for the care which can create the outcome and the value. And that is the way we are moving. And of course, we also need the data. But I also have to say, the reason we are talking about prices is because we have statistics on number of packages which carries a price. So when we have statistics on prices, we talk about price. If we have statistics on bed days, we talk about cost per bed days. So if we are changing the metrics here into more bundled payment, value-based payment, then we are changing also the information system. So I feel this is actually, as I say, one of the real sad things is that because we have a tradition of a payment system, like for example pharmaceuticals per package, that is not an adequate system for modern pharmaceuticals.
All right. Thank you, Professor. Actually, Dr. Tiwari, I want to come back to you on this issue of affordability and so on. If you look at the way India's population is growing with the middle class, what we have is, he actually has the microphone here, thank you. So please leave it with Dr. Tiwari, I'm asking him a question there, thank you. With the increasing, with the growth of the middle class here, the demand obviously, there's a knowledge base that grows, people who are more informed about their needs and their expectations are raised. How has that shaped the move towards the private sector, and how might that change the pricing in the private sector, the affordability and so on? I know there are so many tiers at this stage, and you mentioned that earlier.
I think, can you hear me? Yeah. I think one term, corporate social responsibility, has a major role to play. We are expecting 20,000 crore fund in CSR this year, in next few years. If we can have some percentage of this whole fund, CSR fund, and that can be given to the private sector, we can have a better quality for the poor patient, non-affordable patient. Currently, if patient is non-affordable patient, he is not able to get private healthcare in private big hospitals. That is a problem. He has to spend money out of pocket. But in some states, government are having few schemes, like in Maharashtra there is Jeevan Dayi scheme. In other states, few more schemes are there. Under those schemes, up to certain limit, few procedures and treatments are giving free of cost to the population. But that is a lengthy process. That is not easily and comfortably accessible to all.
So you were saying 20,000 crore going into CSR?
Yeah, it is expected.
Expected. So this would be funds that would help patients who can't afford to go, and that could be used in the private sector to
Yes,
give them
CSR
treatment.
fund can be directed towards healthcare,
Okay.
to develop a robust healthcare system.
Okay, so Dr. Bakliwal, this is an interesting, movement, if you like, that patients can look to support to get into the private health system through the kind of benefits of the CSR that Dr. Tiwari is talking about. How, in terms of designing healthcare systems, in terms of going forward, can that be factored in? Is that something that can actually be factored in as a way to help fund these kind of projects?
If you look at the CSR policy today, there aren't very clear guidelines around what is allowable or not. It's pretty open. That being said, I think where potentially the investment could be used are areas where there are bigger needs in the market, especially in healthcare. So could be around communicable diseases and stuff. There's nothing which calls out that you could use it for diabetes or so. I think there are no clear guidelines on there. That being said, I still think if you come back to the original question, right? I think it's important to understand beyond looking at numbers, what that number's made up of, right? To the point Anita also made around 40% of spend on medicines. I think it's an anomaly. And I'll explain to you why. Because if you go to get hospitalized in a city like Delhi or Mumbai, and you get a cardiac surgery or something done, the cost of that is anywhere between 400 to 500,000 rupees, right? The cost of medicine in there is less than 10%, right? So the point is that it depends on what treatment and care you get and the quality of that care. It's not the percentage of what the medicine contributes or not. So I think to all the data points we're talking about, we should look at the total cost, one. We should then think about what is that cost made up of, to the point we said, well, we need the data. Yep. And every hospital has data. The challenge is there's no transparency around that data, and that's where the issue comes. It's not around data. Actually, there's so much data available in India, it is just unbelievable if you were to put it together, right? It's not accessible. And then the other part is the quality of that care and the cost of that, right? So if medicines were being at 40%, which is 100% of that amount, highly likely that the other components of that care are suboptimal, right? It's not that the prices are very high. So I think we need to segregate the two items and look at quality and overall care and the disease around it to say what can be provided to provide the best benefit, because no one's even looking at health outcomes and the impact of that long term. You could get a surgery done, but you know what, you're back in the hospital after 6 months. That impact is significantly more than actually probably having the right surgery or the right equipment, which could be expensive, or a drug for that matter.
Actually, it's interesting because we'll be talking about this in the data session as well, but this issue of transparency, Dr. Bakliwal, is important because, just taking an example, a friend of mine in Dubai recently had an incident where his daughter fell off a horse, broke her arm, went to the nearest hospital, and I won't name it just in case I get into trouble, but it was supposed to be an established hospital, and the doctor immediately said, we'll need to put pins, and it was a fracture, but they wanted to do major surgery on her. And when he said, okay, that doesn't sound right, for an 11-year-old girl to have pins put in her arm with a fracture, don't you just sling it up? The doctor was trying to fudge around it when he asked, well, how much is it going to cost out of interest? Because he's actually quite a shrewd businessman. And the doctor quoted him 24,000 dirhams, about $6,500. He said, so how do you break that down? He said, well, 10,000 dirhams, about $2,700 is surgery. He said, what's the other 14,000 dirhams for then? And he suddenly started to try to make things up. So there was absolutely no transparency in this. And so I wonder with this, if there's a push for getting more data, whether that kind of transparency will help to regulate the relative proportions you're talking about?
Absolutely. I think if you see European, US, or any of the markets where the government or a payer mechanism becomes strong, right? It's insurance, it could be private or public, or government, doesn't matter. One of the key things which all these systems drive is push for transparency. Whether it's published or not, I mean, we can keep that out. But at the end of the day, that drives behavior in a way of being governance, and it drives accountability in ensuring that you can't just get away with anything that you quote. As well as if you look in some of the other markets, there is a way of how clinical guidelines are followed. There's no clinical guideline followance here, right? There are clinical guidelines, but no one follows it. So there's no protocols, so anyone can be prescribed anything based on what they believe is right versus a protocol. And because the patient pays, there is no payer mechanism, there is no governance and accountability towards that. So I think there is also the overemphasis on the payer systems and the insurance increases healthcare cost.
Right.
The flip side of that, it also drives accountability, right? Because it pushes people to be more transparent, and it gets people to start thinking of things in a much more structured manner than actually doing things. So I think there's a kind of balancing act to look at some of this stuff.
Thank you. I'm going to get a quick question from the back there. Tell us your name. Chris will get to you in a second as well. I'll get to you as well, sir.
It's not a question.
Yep.
Yeah, it's not a question, but a comment. So when we talk about building health systems,
A little closer, please.
when we talk about building health systems, the main objective of building any health system would be to keep the patients not falling ill or keeping the population healthy. The healthcare systems, or the topic of healthcare systems or healthcare industry as such is very well researched. We know what the lacunas are. We don't have sufficient funding. We don't have sufficient doctors, sufficient infrastructure. But a normal human being becomes a patient once he falls ill, and that's when he will require a healthcare system. And we know there are gaps. I feel that. So let's assume it like a funnel. A lot of patients are pooling into the funnel, and they require the healthcare system. But a lot less focus is currently being put on the preventive healthcare.
Preventative.
What are we doing about the prevention of the health of the population?
Thank you very much. Actually, you beat me to it, because I was actually, one thing I was going to talk about in discussing healthcare, designing healthcare systems, is how do we increase the preventative care aspect so that, first of all, we build a strong system that, patients are better informed, patients are better looked after by themselves before they even get to the sort of medical care system. Dr. Wagner, I don't know if you want to chip in on that, how preventative care can also become a key factor in designing a health system. Sorry, you need the mic.
So I think this leads me to think more towards something that we've touched upon, which is actually moving away from a focus on the inpatient high level care towards the community. And I think that is where this shift to both preventative as well as curative care in primary care in the community plays a huge role. And that is where I think there needs to be a focus on making use of different kind of community providers, both for preventative as well as for curative care. Taking things out of the the need for patients to go to hospitals, and that actually meets what we have learned earlier. Some of the needs in this country were. One of the panelists has said that a key issue is the distance that people face from facilities. So bringing care, both preventative as well as curative care, particularly for chronic conditions, to the community through a variety of things. There are some examples that we could share from, for example, Indonesia, where something like that has happened for diabetes, but then others mentioned the utilization of technology, mHealth, eHealth technology, to do some of that.
And yet, ironically, Professor Jonsson, that India also risks suffering from the diseases of the sort of rich world, if you like, with the growth in diabetes, obesity, and so on.
Yeah, I think that so far, I think both in Europe and both in India, I think we have relied on education and information in order to get patients to participate in preventive activities. There has, of course, been examples of economic incentives being used, for example, paying patients to participate in screening programs or to comply with treatment. But I think that there's a fantastic new opportunity in new information technology, because I think that that is an opportunity to also generate data. Because now more and more we can actually generate data, but even before the patient is sick also. So I think that and there's a lot of writings about that. It's very interesting, of course, how probably the whole area and prevention, early detection, etc., could totally be changed by use of information technology, and particularly then reporting back of the data, which the patients get type of a feedback. It's not so good to know, well, in 40 years I will die from lung cancer because I'm smoking. It's much better to get some feedback data in diabetes, etc. So I think that how we create the right incentives here is an interesting, but I think this is also something where maybe the distinction between treatment and prevention, for example in diabetes, becomes a very blurred one, and it's more of a continuous relation. And what we have to be sure of is, of course, that we should not design incentives which goes against this. And I see, of course, some problem, because a lot of these incentives may not necessarily be in the interest of the medical profession, because it will reduce their, say, higher level information compared to the patient, which is leveled out by information technology. So I think here we have a great opportunity. I think here we have also an opportunity for India to leapfrog, because we have been very unsuccessful over decades in Europe of getting anywhere with this.
I won't preempt the data session too much, but Dr. Wagner, you wanted to add a comment, please.
Yeah, I just thought I'd share an example that I was very impressed with I think speaks to this issue of creating incentives that may go against what some stakeholders want, and also trying to do this very hard transition of taking things essentially away outside of the usually more expensive hospital sector. And that example is from Indonesia. So before January 2014 in Indonesia, one of the three insurance systems was ASCES, which insured the employed population. The people at ASCES have had enormously good data on what they're paying for. They looked at those data. They found out that an enormous amount of their budget goes to diabetes care in hospitals. Now, most diabetes patients don't need to go to hospitals. In fact, it is probably better if they have care closer to the community. So ASCES implemented a comprehensive program that consisted of engaging the community providers who had been completely underutilized, frustrated with their profession, engage the primary care community providers to take care of diabetes patients, and give them, they held information sessions, they had patients come back, we can talk about how they were paid on a capitated basis. They were trained by the specialists in the hospital, and because the specialists in the diabetes, the endocrinologists in the hospitals would certainly have objected and did object to this shift of taking patients away from them, which was a source of income for the hospital, they engaged the specialists in other activities, two of them, one being that they made them teachers for the primary care doctors who had to speed up their knowledge on diabetes care, but they also they implemented an sort of something in between, which required the diabetes patients to be seen every 3 months rather than continuously at the hospital, so that the specialists still had an eye on complications and so forth. These primary care doctors also held exercise sessions and nutrition sessions. Those were providing meals in the community doctors' facilities. So a very comprehensive program that tried to structure incentives so that they fit different stakeholders, and so that there could be some buy-in on the part of different stakeholders. Now, of course, the question is, this was a relatively small-scale program. Now the Indonesian healthcare system has shifted, and one of the questions is what was brought up earlier, scalability up to 250 million people.
I'll come back to the issue hopefully in a moment of where the campaigns and where the education can come from, but I wanted to get Chris in here with a question.
Sure, and I really want to come back sort of to the basic premise of the conversation that we've had today. And I've been listening very, very carefully to everybody talking about the importance of incentivizing in terms of outcomes, in terms of building a system.
Closer, please, Chris.
In terms of building a system that focuses more on preventive rather than curative care. And I want to come back to Amit's slides because, you know, one of the great frustrations that certainly I have when looking at the context of healthcare in India and the movement towards a universal environment, it seems to me that the basic premise of universal healthcare is to create as large a pool as possible, which is why we try to move in the area or in the direction of universal, so that you spread the risk for catastrophic healthcare costs across a very, very broad population. And then you base your premiums on actuarial assumptions based on the size of that pool and spreading the risks. Ultimately, what you're talking about is trying to make on the apples what you lose on the bananas, if I could you know, take it down to that simple point. But when we look at the existing healthcare system in India and we throw up examples of private health insurance coverage, I have a lot of trouble of seeing how those are actually private or public health insurance systems. Because if you look at RSBY, basically it's a deductible plan, it's not an insurance plan. People pay a premium, 30 rupees, and they get 30,000 rupees worth of coverage. In essence, it's a deductible. It's not a health insurance system. It's not pooling risks. There's no incentive to generate better outcomes. There's no incentive to keep people healthy. So, Amit, I really do want to come back to you and say, you know, if we look at private health insurance coverage in India, are there any examples where there truly is a health insurance system that's based on defined benefits that determine premiums on the premise of actuarial assumptions of a number of beneficiaries? Because frankly, I don't see how RSBY qualifies as a health insurance system anywhere in the world.
All right, thank you very much, Chris. Dr. Bakliwal, so the question of is there anything, as far as you know, which can serve as a genuine insurance system rather than deductible with the pooled risk and everything?
So the only thing I know of are some of the private insurance companies looking at disease-specific plans, where they're starting to move away from only inpatient to outpatient coverage as well, and starting to think about overall cost and thinking about how do you drive quality and health outcomes. Now, that's not driven out of cost out of medicines, but more around the diagnostics as well as the medical equipment cost. So for new technologies that are coming out, robotics or any of those areas, a big challenge is around what's the real value of that treatment to the health outcome benefit that the patient will get. So I at least know of a couple of companies who are moving in that direction, specifically around the, not so much on the pharmaceutical life sciences side, but more around the medical diagnostics and some of those areas, specifically to one or two disease areas. The challenge, however, is how do you, to the point which raised, because the current insurance system has a ceiling to which it covers, which is so little, there is no way of capturing longitudinal data on a patient, and once the patient walks out of the system, that insurance is seized and then they're out of pocket. So the only source you've got is at the hospital level, and because everything is out of pocket and privatized, it's very hard to be able to pull that out to say what are the kind of areas. Now, that being said, to answer your question, not really, but there are some attempts at least one or two areas which are disease specific to think about how you can drive that discussion. But we're a long way off from where we need to be.
Professor Johnson, you wanted to add to this?
Yeah.
I'm coming from a country where we have a very, very small private insurance market, not because it's not allowed, it's only that I think nobody who's finding it's relevant to pay for it, and of course those who really need it, say like people at my age, they will not get it because they are too old, because they're obviously too high risks. And I think I've just dwelled on that because we have to remember now that with the modern medicine now, focusing on chronic diseases, focusing on the elderly with multimorbidity, which is also be the case here, more and more also, where we know a lot of individual characteristics. We can make a forecast through human genome model, a lot of tests, etc. Who is out going to have what disease? Who's going to respond to treatments also? We have to recognize that there is a significant problem for private insurance. I think because if you are in private insurance, if you like to make money in that market, it is about selection. And otherwise it's about risk adjustment and the public money in. And that is very complicated. So I think that my interpretation from a European perspective, of course, is that the increasing pressure on governments to pay for healthcare is exactly this, that those who are really the need for healthcare in here, they will never get any insurance. So that's and of course we can say, well, the government could go in and subsidize their insurance, and then we are into incentives. And then of course I can give you a lot of economic analysis of how you shouldn't do it, but of course one of the things is of course that the Swedish government has said, we don't subsidize private insurance whatsoever because we don't find any way. We have talked about that the Dutch government has a different than the other governments have. But this is an extremely complicated issue, and it will be even more complicated in the future for these reasons that it is so easy to identify. We can identify the people. What we need to do is, of course, having an effective management of their disease and give them a high-quality healthcare.
The gentleman at the back, you had your hand up earlier in the blue shirt. Did you still want... Oh, no, sorry, to the right. Yeah, sorry, please. I thought it was you had your hand up. We'll get you a microphone, sorry.
Good afternoon, everyone. I'm Dr. Hirsch. I'm representing PPRC, Public Policy Research Center. I have two questions, one for the panel and one for Dr. Tiwari. I want to ask panel the role of, what can be the role of Ayurveda and Unani medicine in preventive? We have seen that it has shown some positive outcomes in preventive healthcare. What is the way in which we can include it and quantify its role so that its effect can be measured and cost can be cut down? The question for Dr. Tiwari is that why do we need CSR fund for corporate hospitals, sir, when already corporate hospitals are built on subsidized land and we are not able to provide poor patients any healthcare, address their healthcare needs when beds are already assigned by to corporate hospitals by government for providing them and they are not being filled. And then directing CSR funds to corporate hospitals for providing healthcare benefit for the poor when it is their responsibility to already provide healthcare needs for the poor.
May I just ask you about that first part? I'll get to Dr. Tiwari in a second. May I ask about the first part of the question? It was the assessment of the value of which sort of medicine?
Ayurveda.
Ayurvedic?
And
Ayurvedic,
yes.
okay. It was, okay. So I wasn't
Quantification, their role and...
yeah. And did you want that to anyone in particular on the panel?
Excuse me?
Did you want that to go to anyone on the panel, that first question?
Anyone.
Doesn't matter, okay, I'll take that in just a second. Can we get a microphone to Dr. Tiwari there, and we'll get to your question, your answer in just a second, Dr. Tiwari. Anita Wagner, let me ask you, Dr. Wagner, if we can look at that issue of, I mean, for example, in the United States and in other places, homeopathic medicine, alternative medicines, as they're seen, don't necessarily carry the same weight. But as the gentleman has very rightly asked, he says, can there be any kind of assessment, for example, of Ayurvedic medicine, which in India obviously is seen as very valuable by a large part of the community? Can that be assessed and then be included into mainstream medicine in a way that, that you feel might be beneficial to designing a strong health system?
Well, I think it is clearly important to make the health system work for the people, and Ayurvedic medicine, homeopathic medicine in Germany plays a big role. Can you assess it with the very same methods that we use to assess allopathic medicines? Probably not. Does that mean it doesn't have value? Absolutely not. So I think we need to understand how to include complementary, I'm not necessarily sure, alternative complementary medicines into the system where I believe they do have a role. And we know that people seek, in addition to allopathic medicine, they seek homeopathic medicine in the United States or complementary medicines of all different kinds. And I think that is part of the system and can't be just neglected.
Did you want to comment on that, Dr. Nielsen?
I guess that's the debate always. I think the real debate is, and the real question is, should the government pay for them or not? And I think the answer is no. Because if we are just saying what we are seeing in now, if we are not really going for outcome, but we at least like to get for evidence-based reimbursement. And then we have to go for the evidence, and I think then the conclusion is, well, if you provide the evidence which we have, right. Because if we are going away, and that's not only for homeopathic drugs, it is other therapies, it's a lot of other things, I think we have to keep to some kind of basis here, because then otherwise it could have quite strong consequences if we base it on some principle of evidence. Value. So then we have to decide, if we are going away from that principle, we are basically taking under the carpet for the pharmaceutical industry and what we have achieved in regulatory and so over many decades.
I think actually that was the gentleman's point, is that maybe perhaps better assessment would be a good idea, and that way it can actually be evaluated far more accurately and then perhaps included based on evidence, as you say. Dr. Tiwari, you actually earlier said you wanted a clear separation between allopathic and homeopathic or complementary alternative, depending on how people see it. I'd like to get your comment on that, then also on the issue of the CSR component and its potential value or not, according to our guests.
I was saying that CSR fund is a huge fund, 20,000 CR. Some portion or whole CSR fund can be diverted to healthcare sector, not for the private sector only. It can be given to government sector also. But some fund allocation from this fund must be directed towards healthcare system. Many hospitals, trust hospitals and other government-aided hospitals, they are serving the people. They have to show their reports on annual basis to government bodies. Like I am in Mumbai, I know Bombay Hospital and other trust hospital. In Bombay Hospital, out of 800 beds, 300 beds are earmarked for the poor patients only, and they are taking treatment at the cost of 0 rupees. Beds are given free. Another hospital is 7Ls Hospital. That is a 7-star hospital in Mumbai, and a beggar can get a treatment in that hospital in the government scheme. So lots of tertiary care hospitals are there, and as per the system, as per the quota provided by the government, they are doing this activity continuously. But that is not sufficient to serve all the poor people. This is the problem.
Thank you, Dr. Tiwari. So, I'll get to you in just a second, man, but the lady there just had her hand up, and then we'll come to you. Oh, sorry, you had it already. Okay. Why don't you just ask your question while you have the microphone and save running around. Thank you.
It's more common to the previous discussion that I really think it's wrong to say, for example, to think about how to implement Ayurveda into mainstream medicine. I think rather to understand we have something like a global medicine more and more, and we can learn a lot from that. For example, in India, the development of a new rotavirus vaccination, I would call it even a frugal innovation, by understanding the different subtypes of the populations much better on very specific characteristics. And I think that already has shown, you talked about evidence, that it's so much more targeted. And I think maybe we will see more of these examples, but I would rather say to bring together this knowledge and a lot of things we see now and observe on more individual level has been described
100,000 years before in other medicines.
I think actually, Professor, we'll be talking about that later when we talk about data collection and the value of that kind of information. We'll get the microphone to the lady there. Thank you.
Hi, I'm Dr. Monica. I work with both government and non-government sector. And recently I got to work with the National Health System UK also. So my question is from the fact that when we were talking about envisioning the Indian healthcare system, you very well mentioned about the healthcare spending and how GDP is not what we need to target when we are talking about healthcare spending, because Thailand, so to say, spends the same amount of GDP as we spend for the healthcare. I'm taking you to the healthcare infrastructure and also to the government healthcare mission. So when we talk about healthcare infrastructure and we talk about doctor population ratio, nurse population ratio, one of the good learnings that I saw from the National Health System is how they have been able to retain their doctors in the same kind of system, which is apparently the world's best healthcare system. And still, the doctors are very happy to work there, even though they're not paid as much amount of the money as the doctors are paid in the United States. Secondly, when we talk about capping the money for the healthcare expenditure, even in a developed nation like United Kingdom, they have put a ring fence budget for providing public health care now. They have been focusing on curative healthcare system, but now the focus is on public health, how they be able to have their clinical commissioning group, how they be able to provide community healthcare workers, and focusing on public health. So now for a country like India, which is a developing nation, we are not able to focus on public health, so to say, and we have been focusing on curative healthcare when we have a mandate of spending 65% of our healthcare budget on primary healthcare. So just focusing on drug price control, fine. Focusing on the healthcare spending is fine. But what about healthcare infrastructure, and what about the healthcare mission of providing accessibility, affordability to all by focusing on public health, so to say? So what would be your idea on that?
Thank you. Valid question. I'm going to put this to Dr. Bakliwal. And actually, it's ironic because you talk about the relative costs and the amount doctors make. My doctor friends in the US seem to make so much money. They also spend a fortune on insurance against lawsuits, and they're expected to have clinics that look like five-star hotels, which is kind of an interesting dichotomy too. But let's look at that, perhaps the idea of public health being a driver for a better healthcare system.
So let me try and answer it in 2-3 ways, right? So I think if you look at pure our physician population in the country, you need to look at it again, you know, the average number and the number of physicians per population, I think, gives you a very distorted answer. So the way to look at this is, if you look at urban India and you look at the metro cities, the number of physicians per whatever metric you want to look at is actually at par or even higher than developed world. So the problem isn't so much, although it is, around number of physicians. It is also around the concentration or the lack of dispersion of them across the country. I think that's one. Second, if you look at the public healthcare facilities, there is a problem around number of facilities which are there, but the other bigger problem is even if you have facilities, they're like a bare shell at times, right? You don't have a healthcare worker. Even if you have a healthcare worker, you don't have adequate equipment to treat the patient. So at the end of the day, to the comments which is made, the patient gets diverted to, in rural markets, to wait for the whole day, get a bus, travel to the next town, come back, and the whole day and the wages are gone. So I think from a healthcare strengthening standpoint, infrastructure is a long-term play. I think it's nice to talk about, but it's not that overnight it's going to change anything. The area which can be improved is around the incentives around getting physicians, healthcare workers to be more dispersed around. In a lot of markets we've seen there is a cap around giving licenses or getting people to practice in certain cantons, zones, whatever you want to call it. I think in India as well, it's one of those things can be driven around how many new physicians can be allowed to practice in a city where you've already got so many physicians, right? A new license can be only given if you're going to go and practice in XYZ, Tier 2, Tier 3 towns, and so on and so forth. And then that drives incentives. It gets, even in UK, you've got the medical license you can't get if you're not going to practice in a particular area for a particular period of time. So I think those things can be driven out of from a public health system, but that's also going to come back around one, visibility of the healthcare infrastructure in the country at the policy level. And we do a lot of work with the government, and I know there are huge holes around their understanding of what the reality of healthcare infrastructure in the country is. People don't even know that. So I think revising policies where you don't even know the basics of what you're trying to treat is disaster. And that's where you see a lot of policy decisions at times are not implementable because you are not able to get down to the brass tacks and look at where the real issue is and to sort that issue out. Is it infrastructure? Is it healthcare workers? Is it equipment? Or is it drugs, right? So all of this needs to be looked at in a very segmented, smaller manner rather than a overarching India view. So I think Europe is a good example when you look at India's like Europe in a way where states become the countries. So how do you drive that and what policies and stuff need to be driven? So there is a lot of work to be done. You need very, very strong central mandate and a lot of clarity and a drive to make that happen. We've seen it in a couple of states, and purely because there was a drive and a vision around making that happen. But how do you multiply it to 29 times is still a big question mark. So I don't know if I answered that question in a rounded way.
Thank you. We'll squeeze one last one in at the back there. We have, sir, bear with me, we're going to do it, we'll do yours after lunch, but right at the back there in the blue shirt. Thank you.
Sorry for backtracking a bit. This question is for Ms. Ranjana and Amit. You did mention, and I totally agree with Dr. Frederick, that competition should be allowed to make the price control, and government should not cap the prices. But don't you think that the industry itself is responsible for what has happened, considering the fact that a lot of prescriptions which doctors are writing today have been driven by the interest created by the industry within the doctor. A lot of prescriptions, 30 to 40% are just fillers. They're not required medications. And moreover, though the industry thinks patients are like patients, but it's more like a consumer. If Unilever can give a freebie on a small stuff like a shampoo, don't you think the pharmaceutical companies can go ahead and adopt some model like that, give out what is really preventive, maybe like a ORS, which is rural areas don't have access to, or something like a soap, a simple soap. And the medication charge is quite high. They can actually give it back to the society a bit on that part.
Thank you. Actually, that was for Ms. Ranjana, who's at the front. If we can get the microphone to her, please. Thank you.
Thank you. I think you raise a very good point, and one of the very positive signs we've seen from the new government, actually on the 1st of January, was a code of conduct for pharma marketing prices, which has come in place. Our particular industry body, the OPPI, has been pushing for this forever, and we are really happy to see that this code is now in place. At this point, it's a voluntary code. But I think, so I think there are two separate matters. One is, the ethics in marketing, and clearly that needs to be addressed, and I'm hopeful that this will be a good first step in that direction. But I think, just the broader concept, just the whole question of what doctors are doing and what pharma companies are doing and so on, I think this is a good first step in that direction. I'm very hopeful. At the moment, it's a voluntary code. It's going to be reviewed in 6 months, which is June. And I'm hoping that we can, continue to strengthen this effort. Thank you.
Thank you very much. Well, ladies and gents, we've reached the point where we will break for lunch. And again, those of you who had questions, hold them, because we will carry on the conversation. Please, a big round of applause for our panelists for their contribution here. Thank you.